today I start my presentation with the lysosome. What is lysosome? Lysosome is an intracellular organelle which contain more than 40%, 40 hydrolytic enzymes which work at pH 4.8. This is the list, important list of hydrolytic enzymes. It converts macromolecule into micromolecule, result help in metabolism of substrate. What is LSD? Lysosomal storage disease. It is monogenic, autosomal, or X-linked disease. In this, specific gene mutation lead to the specific enzyme deficiency, which cause defective acid hydrolysis of the endogenous macromolecule, resulting progressive accumulation of macromolecule in the lysosome, result in enlargement of the lysosome, which cause dysfunction of the multiple cell organelles within the cell, which eventually lead to the irreversible organ damage. This is the picture, and we know this is the picture of rough endoplasmic reticulum. This is the Golgi apparatus, and this is the lysosome. And as we know, acid hydrolytic enzyme mainly stored in the lysosome, but it's synthesized in the rough endoplasmic reticulum, and it transported to the Golgi apparatus for the packaging into the vesicle form, and then at last it is stored in the lysosome. So any defect from the synthesis to the storage, it can lead to the lysosomal storage disease, such as defect in glycosylation, defect in activator protein, defect in membrane protein, and many more. On the basis of the defect, LSD classify into the 5 groups. One is defect of specific lysosomal hydrolase, defect in post-translation modification of lysosomal protein, defect in activator protein, defect in structural lysosomal membrane protein, protective protein, and transporters and trafficking. And fifth one is miscellaneous. They are subclassified into mucopolysaccharidosis, sphingolipidosis, such as Fabry disease, Fabry disease, Gaucher disease, and the Niemann-Pick disease, and many more. I'm not going into the detail of this classification. So there is a need for timely diagnosis. Why? Because LSD is a progressive disease, life-threatening, and it involves multiple organelles. But sometimes diagnosis may be missed or delayed. Why it is so? Because this disease has a large spectrum of presentation. Sometimes patient with same gene mutation present early in the life, or sometimes may be asymptomatic throughout the life. So most LSD are inherited as an autosomal recessive trait, except 3: Fabry disease, Hunter disease, and Danon disease. These are X-linked enzyme deficiency disorder. It can be easily memorized by the mnemonic of HDFC: H for Hunter disease, D for Danon disease, F for Fabry disease, and C stand for female, that is X-linked enzyme deficiency. So good clinical history and thorough physical examination and the judicial use of X-ray can provide a clue to the diagnosis, which is usually confirmed with a combination of the urine and blood test. This is the table which shows manifestation of the lysosomal storage disease. Patient may present with the hepatosplenomegaly, coarse faces, skeleton abnormality, cherry red spot on the eye examination, and many more. So positive finding of cherry red spot help us to narrow down our DD. This is the table which shows in this disease cherry red spot present, and it can be remembered by the mnemonic cherry tree and never grow in a muddy sand. Cherry C for cherry red mucoclonus syndrome. Cherry tree for Tay-Sachs disease. Never Niemann-Pick type 1 disease, never grow, G for Gaucher type 2 and generalized gangliosidosis, never grow in a muddy sand, M for metachromatic leukodystrophy and mucolipidosis type 1, muddy sand, S for sialidosis and Sandorf disease. Apart from these, one is left, that is Fabry disease. So when the patient is present with the coarse faces, hepatosplenomegaly, neurological abnormalities such as muscle weakness, Cognitive impairment. First, take history, proper history, including the family history and history of consanguinity, and go for the thorough physical examination. And if history or examination is suggestive of the any lysosomal storage disease, then we go for the urine screening for the GAG and oligosaccharide and free sialic acid. If there is elevated sialic acid, consider SAID. SAID is sialic acid independent disease. If there is elevated oligosaccharide, consider mucolipidosis type 1, eye cell disease, GM1 and GM2 gangliosidosis, galactosialidosis, ISSD, increase in sialic acid storage disorder, Pompe disease, and monocytosis, and mucopolysaccharide type 4, and the sialidosis. If there is elevation of MPS, go for electrophoresis for GAG. If there is no elevation of GAG or oligosaccharide or free sialic acid, look for the organomegaly. If there is organomegaly, consider Gaucher disease, Liebenfeld type 1, type 2, type C, sorry, type A, type 1 and type C, and mucolipidosis, lipidosis type 1 and C, and Fabry disease. If there is no organomegaly, consider Crab disease, even gangliosidosis, and metachromatic leukodystrophy, mucoliposis type 4, and NCL, neuronal ceroid lipofuscinosis. So for further confirmation, go for the enzyme analysis of leukocyte, specific enzyme defect detection, and mutation analysis of the relevant gene. So first case is Gaucher disease. What is Gaucher disease? Due to the defective action of the acid beta glucosidase, there is a accumulation of the glucosyl ceramide. This glucosyl ceramide mainly store in the macrophage, which we call Gaucher disease. It gives the crumpled silk-like appearance and wrinkled tissue paper appearance on the microscopy, and it mainly infiltrates the bone marrow, liver, spleen, lymph node, etc., which produce symptoms like hepatosplenomegaly, anemia, thrombocytopenia, skeletal abnormality such as osteopenia, and cortical thinning. This is the classification of Gaucher disease based on the neurological symptoms. Type 1 is non-neurological form. It does not present any, patient does not present any neurological symptoms. In type 2, in this there is severe neurological symptoms, and patient mainly present in early infancy, and death usually occur by the age of 2 years. Type 3 is a chronic neuropathic form. In this patient, patient has neurological symptoms, but it occur late in age, occur in childhood or adolescence, and it is less severe than the type 2. So this was the patient which admitted in 2010 in our institute under our director, sir, with a complaint of hepatosplenomegaly and abdominal distension. होच्छिलो ना तो उधर से कॉपी नहीं हो रहा था उस दिन हमने सर फोटो तो लेता. So skeleton survey was done, which shows the cortical thinning and the osteopenia and the classical Erlenmeyer class deformity. And this patient bone marrow biopsy was done, which was suggestive of Gaucher disease. And for the confirmation of Gaucher disease, we did enzyme assay activity, which was suggestive of the Gaucher disease. Beta glucocerebrosidase low, which is high. So that patient was treated with the imiglucoserate at the dose of 60 unit per kg. Yes. Okay. It is treated with the imiglucoserate with the dose of 60 unit per kg per every 2 weeks. And this is the this is the picture of that child which admitted at the 6 year of age, and after starting enzyme replacement therapy at the 12 year of age. This is the picture, and now that baby is this baby is 18-year old, and he is doing well in life, and he is on enzyme replacement therapy continue. Second case is an 8-month-old boy is brought to the pediatrician by his parents because he has recently lost the ability to crawl or hold his toy. On examination, the patient is tachypnic, breathing with considerable effort. The liver is palpable, 5-finger width below the right costal margin. X-ray of the chest revealed cardiomegaly. He has a difficult time sitting upright. Despite a number of interventions, the child's symptoms continue to worsen until his death 2 weeks later. On autopsy, it is likely that the patient's cell will contain accumulation of the substance. And this is the X-ray of that child with cardiomegaly. And on examination, the child was floppy, hypotonic, and there was a history of feeding difficulty, delayed milestone, and elevated plasma creatinine level around 2000. So these were the symptoms due to accumulation of the Bis substance. Before giving the answer of this question, I would like to introduce the second disease, that is Pompe disease. Pompe disease is a result from the deficiency of lysosomal acid alpha glucosidase. Gaucher disease is caused by the beta glucosidase, and this disease is caused by the alpha glucosidase, which break down the glycogen into glucose, result in accumulation of the glycogen, which mainly affects the muscles, cardiac muscle, skeletal muscle, and smooth muscle. So, diagnosis of Pompe disease is important, and newborn screening help us to diagnose the Pompe disease early. But other tests like enzyme assay activity on the lymphocyte, we can also do. But for accurate enzyme assay activity seen in the spleen fibroblast, but it is invasive test and require 4 to 6 weeks. And it also confirmed by the muscle biopsy, but absence of glycogen in muscles does not rule out the Pompe disease. As Pompe disease, patients should treat it with the enzyme L-glucosidase alpha, and it was prepared through the recombinant DNA technology. Okay, next is Fabry disease. It is X-linked LSD. Fabry disease is caused by the deficiency of alpha galactosidase, result in accumulation of the glycosphingolipid substrate and the globotriaosylceramide ceramide in the lysosome. Fabry disease usually present with the tingling and numbing sensation of the palm and sole. But from this, there is a classical angiokeratoma. It is the raised purplish red non-blanching rest which present around the mainly around the umbilicus and the buttock. And sometimes patient may present with the markedly dilated vessels on the conjunctiva. And Fabry disease should be treated with the enzyme alpha A-galactosidase beta enzyme. Recommended dose is 1 milligram per kg body weight at every 2 weeks. GM1, GM2 gangliosidosis. It is due to accumulation of the gangliocytes. GM1 gangliosidosis is caused by the mutation in GLB1 gene, resulting in deficiency of beta galactosidase. GM2 gangliosidosis include the Tay-Sachs disease, Sandoz disease, and GM2 activator deficiency, which caused by the due to mutation in the HEX-A gene, HEX-B gene, and G12A gene, respectively. This is the patient which admitted in our institute with a complaint of force, feces, abdominal distension, hepatosplenomegaly, and persistent Mongolian spot. And it diagnosed as a GM1 gangliosidosis. And on X-ray, we found dysostosis multiplex, means the enlargement of sella turcica, oar-shaped ribs, ovoid vertebral bodies, and the broad and proximal bones of pointed bones of the hand. So, Send-off disease. It has similar clinical course as stasis disease, such as neuronal weakness, myoclonic jerk, regression of the milestone, etc. But stasis disease is caused by the deficiency of hexosaminidase A, but send-off disease is caused by the deficiency of both hexosaminidase A and B. And this is the child 2-year-old girl which diagnosed as a send-off disease. She was severely mentally retarded and has the extropia in her eyes. Diagnosis was suspected after finding the cherry red spot in her retina. Chalidosis. Chalidosis is caused due to accumulation of the deficiency of the alpha and acetyl neuraminidase in leukocyte, result in accumulation of the oligosaccharides and elevated amount of cellular oligosaccharide in the urine. It presents with the coarse feces, gum hypertrophy in early infancy, and vertebral changes. Gum hypertrophy may be present in other diseases such as mucolipidosis type 2 and the congenital disorder of the glycosylation, sialic acid storage disease, and aspartoglucosamine. Fabry disease. Galactocerebrosidase deficiency leads to the accumulation of the galactosyl ceramide exclusively in the myelin sheath, result in the spasticity and the cognitive impairment. It is on MRI. It shows the non-specific pattern from the white matter around the occipital pole of the lateral ventricle. It also seen in the adenoleukodystrophy and metachromatic leukodystrophy. Fabry disease. Accumulation of the ceramide due to the deficiency of acid ceramidase. The child usually presents with the multiple joint swelling with subcutaneous nodules. Sometimes this kind of patient misdiagnosed as a rheumatoid arthritis, but this patient diagnosed as a Fabry disease on the biopsy. Wallman disease. It is an autosomal recessive lysosomal disorder caused by the deficiency of acid lipase, and it presents in a first few weeks of life with a failure to thrive, vomiting, abdominal distension, hepatosplenomegaly, and on X-ray, this is the X-ray, and this shows the adrenal calcification of the adrenal gland, and this kind of patient usually die within the 6 months of life. So, treatment of lysosomal storage disease. Lysosome storage disease caused due to the defective lysosomal enzyme. So, enzyme replacement therapy and the hematopoietic stem cell transplantation is a main therapy. Apart from that, gene therapy is also available, but not for the all disease. And symptoms due to accumulation of the substance should be treated with the available medicine and the surgical procedure. And the substrate reduction therapy is also helpful to reduce the storage of the accumulated substance. This is the list of modality and the disorder treated, such as hematopoietic stem cell therapy, bone marrow transplantation, umbilical cord blood transplantation, and peripheral blood stem cell transplantation. And this is the disorder which treated with the transplant. And this is the list which enzyme and the corresponding disease which treated with the enzyme replacement therapy. Toward the end of my presentation, I want to just say a few things about the importance of the N-luteri. As studies show, like 55% of infants suffer from one or more functional GI disorder, which affect the sense of physical and emotional well-being of the infant and family and or caregiver. The gut microbiota has a greater influence on the gut comfort during infancy and early childhood. And studies show the efficacy of L-luteri is beneficial in both for management and prevention of infantile colic. And L-luteri is more efficacious than the smithicone and lactose.
Now, lysosomal storage disease, I think, very not that uncommon. 1 in 7,000 is the total incidence of lysosomal storage disease. So then again, I say that that means every 3 cases of congenital hypothyroidism, you are supposed to have 1 lysosomal storage disease. But we do miss. And we miss because when a child comes to you with pain in the legs, severe pain in the legs, and you cannot find out any cause for that, still you don't think of that this can be the earliest presentation of Fabry. And I don't blame anyone. Even we have thought of a lot of conditions in one of the child that presented to us with tremendous pain in the legs. We didn't find anything in the brain, anything in the nerves, but still we didn't think of that this can be the first presentation of Fabry. I had a patient who had normal child but proteinuria of 0.5 protein creatinine ratio. But still, I didn't think of that this can also be the first presentation of Fabry disease. When it goes to conjunctiva, you see conjunctivitis, but you don't think that this can be also the first presentation of Fabry disease. Similarly, angiokeratoma corpus diffusa. So these are the varied presentations according to the age. A few days back, I had a patient who had just an isolated cerebellum. I did think of that it can be portal hypertension and did that portal hypertension. But I should also think of the moment it is not portal hypertension, isolated splenomegaly, think of Gaucher disease. Think of Gaucher disease because that's one of the presentations they can have in the visceral presentation. For Gaucher, we have a patient who is being on treatment for last 12 years and is doing fine. And if you can diagnose and treat Gaucher, but unfortunately, the treatment of all these medicines are very, very costly. But this medicine, this child is getting because of the first few cases, they have given medicine free. And I think this child, this young boy, he works in a corporate sector. He passed engineering and works in a corporate sector. He has done his BE. So after that, Gaucher, we know that Niemann-Pick disease can be a presentation. We had a presentation a few days back. A adolescent girl was coming with falling down. Came to me, but it was investigated, but it was not investigated for Niemann-Pick disease. So this is an older child presentation of Niemann-Pick disease type C, and there is a treatment like substitute replacement like Neglustat and Iglustat, which is available. But I'm not very sure that how much result they will get with that. When a patient presents with jaundice in the neonatal period, we do not think of that it can be Niemann-Pick disease. Also, it can be a presentation of other lysosomal storage disorders also. Recurrent vomiting, diarrhea, abdominal distension. How many of us do think of, okay, let me have an X-ray of the abdomen to see, and adrenal calcification. And that is one patient. We didn't think of adrenal old man disease, but we did think of, after seeing the X-ray, that it is a very classic adrenal calcification. And now there is a treatment for that. Lysosomal acid lipase. LAL. Lysosomal acid lipase. There is a treatment for Ullmann disease. And if you look for Ullmann disease, one of my colleagues, he's a consultant gastroenterologist in UK. He's working on Ullmann disease. So there is a treatment for that. One of the case of Barber, I've seen that was being treated as an arthritis. But the nodules of the Barber disease that we have shown are very characteristic. And it's a very painful condition. But it is confused with sometimes that, as she said, very nice presentation within a very short time. She has presented it very well. Because I told her the last week, and she presented it the next week, because I did the same thing which my boss did with me, I did with her. I remember about 30 years back, my boss told me in England that, why don't you have a presentation on this? I said, okay, sir, I will do it. I prepared it. And then he said, next week I have a presentation on this. So, so you made the presentation for me, and I'll be presenting that. But anyway, I had the presentation because I have presented on this. But this is a classic case of Fabry disease that we have. And what is necessary for the residents are what I'm get confused, the GM1 and GM2. Which one contains which group? GM1 classically presents with your extensive Mongolian blue spots, and also the cataract, cherry spots and others. Inguinal hernia also they can present, but the extensive Mongolian blue spot is very classic sign. But what about the GM2? GM2 has got two diseases. She has added a third one, which is a new one, ganglioside activator deficiency also. But GM1, GM2 is Tay-Sachs, and Tay-Sachs and Sandoff are similar. Only thing in Tay-Sachs, you don't have any hepatosplenomegaly. In Sandoff, you also have the hepatosplenomegaly along with the features of Tay-Sachs. Tay-Sachs will come to you arching back, hyperacute, কত ভীষণ আওয়াজ শুনলেই চমকে ওঠে। Start thinking that is most probably normal, but if it is too much, and also see that whether the patient arches back, that's very classic, that they will arches back, and it's not that uncommon in Ashkenazi Jews. But in our country, I don't think I've seen more than 2 cases in my 42 years of career as cases. Maybe we have not been able to diagnose some of these cases. And Sandoff is similar that with hepatosplenomegaly. You have, along with the features of Tay-Sachs, and you have also the cherry red spot. And always look for cherry red spot. She has omitted one slide where I tried to show that what organs you should see. Starts from the brain, look at the eyes, look at the hepatosplenomegaly, look at the bone change. I always try to do a skeletal survey in these cases. About Gaucher we have shown, and skeletal survey we do because MPS, mucopolysaccharidosis, are again a big group of lysosomal storage disease and can be very well diagnosed by skeletal survey and the clinical examination, apart from the enzyme. You know, this Hurler syndrome has the corneal clouding along with hepatosplenomegaly, and the classic changes of radiological changes that we have. I'm not going into the details of that. It has got three types: classic Hurler, she, and Hurler she. She is very mild, and Hurler is the severe response. And they usually don't present before 2 years of age. If a child presents before 2 years of age, instead of thinking for Hurler, think of mucolipidosis or eye cell disease. They will not present, Hurler will not present so early. Gum hypertrophy, as she has shown, that can be a presentation of gangliosidosis and eye cell disease or mucolipidosis. So these are the one mucolipidosis type 2. Carbohydrate deficient glycoprotein disease, abnormal deposition of fats, cardiac glycosylation effect as it is called now. Abnormal deposition. I have a patient I will show someday the abnormal deposition of fat in various areas. Think of carbohydrate deficient glycoprotein disease. And then after the first group, type 1, hypoglycemia is not the transferrin focus, TFE focus. Hypoglycemia, I don't think it's a feature of. I cannot remember. I don't have. Metabolic regular type আছে regular type আছে এইসব জায়গাতে it's a very uncommon, but the type 2 Hunter syndrome, I think I have brought one Hunter syndrome. বাইরে দেখতে একটা পেশেন্ট আছে কতগুলো বলতে আছে ওটা টাইপ আছে একটা টাইপ আছে
last point about and presently adult. Lots of adult fatigue for this. I mean, what we always say in FLP, they don't have any history of alcohol. Ideally, we should also investigate for that makes sense. Because they also they can just present with fatigue. So minor difficulties they can present with that.
It's a milder form is there.
Nowadays, it becomes that clarity. All
Then after the type 1, coming to the type 2 Hunter syndrome, it has got two types. Type 2 beta, they have the nodules, skin nodules in the back, and they don't have the corneal clouding. Remember always they don't have the corneal clouding because Hunter will not be able to see. Then you need to know which one has only neurological. This is for the postgraduates, which is only for the neurological. Remember that the San Filippo is the only neurological. It has an N in it, so it will have a neurological features. Neurological features. And then Marotex-Lamy, it doesn't have an N, so it doesn't have a neurological features. Marotex-Lamy and Natwick syndrome disease are the ones which has a skeletal presentation. Morquio is one which is mainly skeletal, and the question may be what is excreted in Morquio. Remember Morquio, K. So they will have keratin sulfate. Type 1 has dermatan sulfate and heparin sulfate. And then is Sly syndrome, Sly disease, and others. So that's about, and pycnodysostis is one of the cases which can present with bone. I think I presented one. Ectodosis with bone changes only. So that's all about lysosomal. This is just a primer. Neuronal ceroid lipofuscinosis is one of the most common in UK. It's one of the most common. You have the bullseye appearance in the macula, appearance in the macula, which is very characteristic of neuronal ceroid lipofuscinosis. There are Hawk-Hanedy, Harada syndrome. There are different types for that. That is for the metabolic specialist. For us, little bit of lysosomal storage disease is important. And anything, thanks again to Nidhi, because she has really presented well within a short span of time.